A very good morning to everybody on this conference. My name is Vijay Nambi. I am a staff cardiologist at the Michael E. DeBakey Veterans Affairs Hospital in Houston, Texas, and also an associate professor of medicine at Baylor College of Medicine. Um, I'm going to talk to you about an interesting topic of use of troponin in the prevention of cardiovascular disease. Just to get disclosures out of the way, primarily most of them are related to research. I'm supported currently by a merit grant of the VA, also supported by NIH in the past. I do co-investigate on a provisional patent that was filed using this biomarker for biomarkers on heart failure. So we all have come to realize or recognize troponin, and it's found in different forms and different places. Cardiac muscle being one of them, and skeletal muscle being the other. There are chiefly three isoforms of troponin, as you can see: troponin T, troponin I, and troponin C. Of these three isoforms of troponin, troponin T and I have sufficient similarity between or sufficient differences between the skeletal muscle and the cardiac muscle isoform. So that's why they are used in cardiac diagnosis. On the other hand, troponin C's isoforms between the skeletal muscle and the cardiac muscle are different, as a result, are similar, sorry, and as a result of that, we do not use troponin C in our regular cardiac diagnosis and markers, if you will. Now, troponin generally can be found in a few locations. In the cytosolic pool, that's about 6 to 7%, and in a bound form. When you have an acute injury, such as when you have a heart attack or something like that, initially we think that the cytosolic pool is released, and that's the initial bump in the troponin that you would see. Subsequent to that, there's destruction of the myofibrils itself, and then the bound form of troponin gets released. So this is the classic mechanism by which we think troponin gets released in the setting of an acute injury. Now, as you know, troponin's been recognized as a marker, and people use it for diagnosis of myocardial infarction, unstable angina, basically acute coronary syndromes. The current ACC-ESC guidelines would suggest that having greater than 99th percentile during the first 24 hours after a clinical event are indicative of a myocardial infarction. Also, this requires ACC-ESC guidelines suggest that the coefficient of variation for these markers should be less than 10%. And this is why the lab values can change slightly between lab to lab and hospital to hospital, because of this dual requirement of levels greater than 99th percentile and also a coefficient of variation less than 10%. Now, theoretically, we always use troponin for the diagnosis of myocardial infarction, as we discussed, but over the last decade or so, or more, people have started recognizing that troponins get released at other times too. In other words, a non-myocardial infarction mechanism. In this slide, you see several non-thrombotic causes for the elevation of troponin. And what you will notice here is things like demand ischemia. You will also notice myocardial ischemia, which we talked about. And demand ischemia can come in several situations, such as hypotension, sepsis, supraventricular tachycardia, just having LVH. We also have direct myocardial damage, which can result from an injury, cardiac confusion, what have you. And finally, you can have other situations such as a pulmonary embolism and other kind of pulmonary causes for which the troponins have been shown to be elevated. Now, recently, within the last few years, a newer generation troponin has become available. This newer generation troponin measures troponin at about 10-fold increased sensitivity. In other words, it can, what was used to be called undetectable, the newer generation troponin can detect them at a 10-fold improved identification of this. Now, troponin T has come up with a newer, higher sensitivity version, and troponin I has also been developed. For the sake of this talk, I'm going to focus on troponin T, which is where most of my data or the data that we've generated has come from, and that's what I'll be discussing. But similar parallels can be drawn to troponin I. There are some differences in the characteristics which we won't delve into at this point of time. So the conventional assay, you can see there the 99th percentile in a healthy population. The conventional assay is about 0.01 micrograms, while for the higher sensitivity assay is about 10-fold decrease as far as that goes. The 99th percentile is similar, but the coefficient of variation is achieved at a lower level for the higher sensitivity troponin, and the lower limit of detection is about 10-fold more sensitive as far as the troponin, higher sensitivity troponin itself goes. Essentially, now with this higher sensitivity troponin, it changes the playing field a little bit. One is you still have its use for your acute myocardial infarction and all the traditional things we've used it for, which includes PE, myocarditis, and other situations. But in addition to it, this is the same. The slide goes through the tip of the iceberg concept, wherein what we've been using it for is essentially the tip of the iceberg. Now you have a huge portion of potential use which is submerged, and I take you to the place which I've circled down below, which is just general population screening and community screening. This is what I'm going to focus the rest of this discussion on, to try to highlight potential uses of troponin or how it's coming to the fore for uses in these situations. So the fact that troponin is measurable in a healthy population, data comes even from the older generation of the troponin, not the newer one, but even the older generation of troponin from the Dallas Heart Study. Here you can see that there was a 0.7% prevalence of troponin in the Dallas Heart Study population. And this is with the old generation troponin. The Dallas Heart Study is a middle age or a lower age group. And what they found in this study was the determinants of who had these measurable troponins were individuals with diabetes, individuals who had LVH, who had congestive heart failure, and chronic kidney disease. Now, if you had more of these risk factors, the chance that you had elevated troponin was higher, with people having more than 3 of these risk factors, namely diabetes, LVH, congestive heart failure, and chronic kidney disease, having almost a 35% prevalence, or 35% of them had elevated troponin levels. Now, the key for this is with the older generation troponin. Now, with the newer generation troponin that came to fore, you had the ability potentially to detect more people with such abnormalities. So around the same time in 2011, 3 studies looked at this higher sensitivity troponin. The Dallas Heart Study is the one in the left over here, of this left of me, and I guess to the right of the screen. The Dallas Heart Study was a younger age group, 30 to 65 years of age. They had about 3,546 individuals, and they had a 6.4-year follow-up period. They measured troponin both with a standard and a higher sensitivity troponin assay. The interesting thing about these 3 studies, as you will see, is all of them had unique advantages and unique key points that were helpful. So the Dallas Heart Study focused on a younger age group. The ARIC study focused on a middle age group, and the ARIC studies which I've been a part of. And there they had about 10,000 individuals, so seemingly the higher number of individuals, a middle age group, as you can see. And then the outcomes or the endpoints were well characterized in the ARIC study. Finally, this cardiovascular health study was an older age group, greater than 65 years of age, with a good amount of follow-up. And their advantage was they had troponins repeated at in 2 to 3 years. In other words, they had 2 time points. So overall, each study had unique advantages. The Dallas Heart Study were not rich in events, but they had very good endpoints, which were including MRI, EBCT, and other cardiac phenotypes. The ARIC study had robust endpoints with heart events, heart failure, and things like that, while the CHS had repeat troponin at a couple of time points. So all of these were published around the same time as I talked to you, in 2010 and 11. The Dallas Heart Study and the CHS were published in JAMA, while the ARIC study was published in Circulation all around the same time. So I'm going to focus on the ARIC study and go through how troponin, these higher sensitivity troponins, have been associated with events. So few assay characteristics that are useful. The limit of measurement is about 3 nanograms per liter for the higher sensitivity assay. The limit of detection is 5. The measurement range is 3 to 10,000, and the limit of quantitation is 13 nanograms per liter. All of these just basically are assay characteristics wherein your reliability is increased, etc. So the first study, as I talked, what I want to discuss is the ARIC study, where this is a population-based study of cardiovascular disease incidence. The study started in about 1987, and it's still continued at this point in time. Initially, there were about 15,000 individuals enrolled in this study. For this specific analysis, we used the 4th visit in the ARIC study, where there were about 9,698 individuals. Now, these included individuals who did not have CVD. In other words, these were healthy individuals or relatively healthy individuals who had no CVD or no associated events. So we looked at whether high sensitivity troponin can predict CHD mortality and heart failure hospitalization. Now, when we did this analysis, we classified the ARIC individuals into a few groups. Those with undetectable levels were those we call the reference group. Now, you can see here right away that there were about 66.5% of the individuals who had a detectable troponin level. 66.5%. In other words, 2 out of 3 individuals who were middle-aged, who were healthy relatively, I mean, they could have risk factors, but they were relatively healthy, no events, were all having elevated troponin or measurable troponin. I wouldn't say elevated troponin, but more measurable troponin. Then we divided this remaining 66.5% of the individuals into groups, basically looking at almost tertiles. So we had 3 to 5 nanograms as one group, 6 to 8 as the second group, and then we divided the higher groups at the 90th percentile, which was about 0.13, which incidentally was what the older generation assay could measure troponin at. So then we looked for associations between troponin and various events. And for this, we really adjusted for a lot of risk factors. One of the initial thing was, yeah, if the troponin is elevated, it's probably a kidney function. So we adjusted for everything. Age, gender, and race was the first model. For the second model, we adjusted for things that would constitute a cardiac risk score, which would include, similar to the Framingham risk score, but something derived in the ARIC study, which included cholesterol values, blood pressure, antihypertensive medication use, smoking status, and presence of diabetes. In addition, we further adjusted in the third model for HSCRP, NT-proBNP, and for glomerular filtration rate. In other words, we adjusted for everything that you can think of, potentially associated with heart disease that we had available. For heart failure and mortality, since there are no established risk prediction models, we used the same model that we had for CHD prediction, but we also added things such as BMI, left ventricular hypertrophy, and creatinine to get a more robust prediction model. Now, this is a busy slide, which basically compares the different groups of troponins, those undetectable to higher levels, by their baseline risk factors. I'm going to show you in the next slide what were the significant differences between the groups. Here you can see the significant differences between the groups. These included basically people with diabetes. People with diabetes had, more of them had higher levels of troponin. Interestingly, for cholesterol, it's the lower group that had the higher troponin. In other words, if your cholesterol levels were higher, you're more likely to be in the lower group. Kidney function clearly went also, as your troponin levels increased, your kidney function went down. But you can clearly see that the eGFR, even in the high risk group or the high troponin group, was not that bad. A 76.8 ml per minute is, it's a good eGFR. C-reactive protein increased across the group, primarily in the highest group. BNP clearly increased as the troponin levels went up. And finally, LVH also increased as far as the troponin levels went up. All the others, as far as baseline characteristics, were similar across the groups. Now, the next slide goes over the distribution of troponin, and you can see clearly a skew in the distribution of troponin with a huge number of people in the undetectable, but remember this overall still constituted only 30 to 35% of the individuals. The rest of them were distributed across the spectrum of troponin, spectrum of troponin values, as you can see the arrow pointing out over here, and overall together this was about 2/3. Now, in men, there were more number of people, higher proportion with the detectable values. You can see the undetectable in men was only about 16 to 17%. On the other hand, women, there were about 40 to 45% of the individuals who had undetectable troponin. All the others had detectable troponins. Now, when we started looking at the association with events, this slide just shows you a total number of event rate by categories, by troponin categories, and looking at all the events. If you look at all CHD, you can see in the first column, there's a clear increase as far as the events itself go. You can see what happens is you had 8.5% of the individuals, and it goes all the way up to 25% of the individuals as the troponin levels went up. If you looked at only hard CHD, a similar story emerged with the incident rate going up as far as the troponin levels go up. Interestingly, at the outset of the study, if you had asked us, we would have said maybe it's a CHD that would have been best predicted by troponin. But what you see here is mortality and heart failure hospitalization. The event rates were even more robust with higher number of people having events as it went through. Now, if we looked at the risk here, you can see for heart disease or CHD, that levels went up as far as each risk group went, but clearly group 5 was the one that had the highest risk of events, as you can see established by this blue line over here in the Kaplan-Meier curves. But the other important thing was even at the lower risk group, you started seeing a difference emerge, even at this lower risk group. Why is this important? Up to group 4 would not have been detected by the previous generation troponin. Group 5 would have been detected by the previous generation of troponin. Now, a same story emerged for death. You can see a similar story with the highest groups having the highest amount of events. And a similar story emerged for heart failure, with the risk of events going up as far as the heart failure goes, as far as the troponin levels go. But interestingly, for heart failure, even at the lower levels in group 1 through 4, you started seeing the curve split up even at that point of time. Now, the hazard ratios, when you looked at it comparatively, you can see in this slide that people with heart failure had the highest hazards, you can see, compared to all of the other things. All-cause mortality was the next, and then you had incident CHD. Now, I just want to take you over to the y-axis over here to see that the overall hazard ratio. The hazard ratio for incident heart failure was almost 8 to 9. Among all biomarkers that we've worked with, there's not been as robust a marker that we've seen with univariate hazard ratios up to 9. And even after multivariate adjustment, it was on the order of 3, 4, or 5, which suggests a significant association with that. Now, even for all-cause mortality, essentially, the hazard ratios are about 5 or 6. Essentially, this marker, if you ask my mentor who's done a lot of work on biomarkers, is among the strongest biomarkers that we have seen as far as association with incident cardiovascular disease events itself go. The next question we asked was, can we actually improve risk prediction? Now remember, risk prediction does not, and association alone is not sufficient to say, claim improved risk prediction. For you to say there's improved risk prediction, you have to go through statistical tests of discrimination and also calibration. Discrimination basically would mean tests that say, do you have disease or do you not have disease? In other words, how well is your marker able to split, differentiate between those who have and don't have disease? And calibration basically says, if I say an individual is going to have disease, how well does my model of prediction of disease go well with what was observed? In other words, the expected and observed, how well do they tie with each other? For these, we use various statistical tools. For the discrimination test, we use things like differences in AUC, or the area under the curve. We also use other things such as IDI. We also use other things such as the NRI, which are all listed over here. Now, essentially, what this means is an NRI is one of the newer tests that have come up as far as statistical knowledge goes. And what that does is it also stands for Net Reclassification Index. In other words, if I add a marker to a risk prediction score, it's going to classify some people to a higher risk group and a lower risk group. The key is, how good was this risk reclassification? If you were classified to a higher risk group and you ended up having an event, that is a good reclassification. On the other hand, if you were classified to a low risk group and you had an event, that's a bad reclassification. So essentially, the NRI summarizes the good and bad reclassification and comes up with a number. Now here you see, for prediction of all CHD and ARIC study, you see the overall group among women and among men. Consistently adding troponin increases your AUC, which is a test of discrimination. The model fit improves overall, not for CHD though. And the net reclassification index is about 4.5% or so. Comparatively, for C-reactive protein, for example, the net reclassification index in other studies have been about 6 or 7%, but we didn't find the same amount in our study. Now, the next slide goes to hard CHD, which excludes revascularization. And you see the association is even more robust. And you can see here that the AUC improves, your overall model fit improves, and your net reclassification rate is actually about 10%, suggesting that the reclassification helped, a tenfold good magnitude as far as that goes. Mortality was even more impressive. The AUCs increased really robustly, and you can see the net reclassification index also improved across the board, be it in men, women, or in the overall group. And finally, for heart failure, the risk improvement was, the most spectacular, with really improved AUC and also the net reclassification index itself. So when we compared the three popular markers, hsCRP, NT-proBNP, and troponin T, what we found was, across the board, troponin T seemed to do better than C-reactive protein. Here you have troponin T net reclassification index for all CHD, and you can see that it was better than NT-proBNP or hsCRP. The ones in the golden color on the slide are things that were not significant. All the other ones in the white font are significant. You can see troponin was better than C-reactive protein and NT-proBNP for all CHD, and for hard CHD, both troponin and BNP are comparable, but clearly better than C-reactive protein. Now, if you went on to the all-cause mortality and to heart failure hospitalization, clearly troponin and BNP did far, far better than C-reactive protein and were comparable to each other, as you can see over here. So overall, this suggested a robust reclassification and that there was significant value of troponin and NT-proBNP in risk prediction for all-cause mortality, heart failure, and for CHD itself. Now, other studies I told you, Dallas Heart Study and the CHS looked at similar information, and they emerged with similar results. Here you can see a similar cut points as we talked about for the ARIC study, and overall the results were consistent with all-cause mortality going up in the highest troponin risk group areas, and again showing an increase across the other other troponin categories. Now this slide basically summarizes what happens if you look at other categories. Important things to take home here are, if you had a troponin T that was negative by the standard troponin, in other words, the previous generation troponin was negative, still you had a high hazard ratio for all-cause mortality. If you had LVH or CVD or not, or CKD, in other words, you had no CVD or CKD, it still stood that the association was strong. If you had no LVH or LVH, the association was strong. Essentially, across any subgroup, the association of troponin with all-cause mortality was noted in the Dallas Heart Study. A similar finding was seen in CHS, where they showed also further that differences in troponin over time also predicted events. People whose troponin went up over time had worse events compared to people whose troponin stayed stable or whose troponin actually decreased over time. Now, this threw open a lot of questions. How better can we use troponin to further evaluate heart disease risk? Now, Dallas Heart Study looked at a very interesting concept where, as I mentioned before, they had cardiac MRI, and they looked at myocardial mass. And as you know, myocardial mass is strongly associated with incident heart failure and incident cardiac events. So they looked at LVH and saw what happens if you had troponin that was detectable or not. Now, here is the Kaplan-Meier curves. And this is a slide with, it may be difficult to see, but essentially what this shows is if you had no LVH and your troponin was negative, in other words, it was not detectable, you did the best. Now, if you had both LVH and troponin was positive, you did the worst. Now, interestingly, whether you had LVH alone or troponin alone, you did worse than people who had both negative, but you can see there's a clear difference between those who had both LVH and troponin. The same story was there for BNP also, where if you had both LVH and BNP, you did far worse than people who had either present or none present. Now, when you look at all of them together, in other words, if you had LVH and high troponin and high BNP, your outcomes were really, really bad, as you can see over here. Now, the one in the green here were people with LVH and either troponin or BNP present, and these were people with everything negative. Overall, this suggested that for you to have outcomes, in this case it was mortality, you had to have, LVH alone or BNP and troponin elevation alone, the mortality wasn't that high, but the combination of that seemed to have a huge value. In other words, what this data was suggesting to us was that if you had LVH alone, perhaps the damage is not done as much, but if you had detectable troponin, that suggests structural injury that's ongoing and perhaps suggests the people with a higher risk of outcomes or events over time. Now, we talked about troponin and BNP and heart failure prediction, but remember we talked about how the models we used were not, specifically geared towards heart failure, because at that point of time, no, heart failure models were published at that point of time. Since that publication of that paper, we had an ARIC heart failure model published, and so we looked at does troponin and NT-proBNP actually improve heart failure risk on top of a heart failure prediction model. Two things we studied was whether it added to the heart failure prediction model, but in addition we saw if a simple model that included only age, race, sex, and the troponin and BNP value, or we call this a lab report model, can perform as well as the clinical ARIC heart failure model. Essentially, to summarize the study, what we found was that the lab model did as well as a clinical ARIC model. In other words, if you had just troponin and BNP values, your outcomes, your NRI and everything were similar to a clinical model alone. But clearly the best model was when you added the clinical risk scores and added troponin and BNP to it. Again, this suggests the value of troponin and BNP in prediction of heart failure, even the simple lab tests, much similar to having a hemoglobin A1C or having a EGFR reported on the thing. As you know, there have been some studies that have suggested that just a report on the values on the lab slip, which are abnormal, has value or has additional benefit to it. So this data suggested that troponin clearly, along with BNP, can improve prediction of heart failure model. We further looked at it for other risk factors. We recently had a presentation at ACC where we showed that blood pressure alone, when you had high blood pressure alone, If you had a blood pressure of 140 to 159 and undetectable troponin, your outcomes were actually better than if you had a blood pressure of 120 to 139 when you had elevated troponin. Basically, what this is suggesting is that troponin is identifying structural injury to the heart. If you have structural injury to the heart, your outcomes are going to be worse. Troponin is picking up in healthy populations. Detectable troponin is picking up structural injury to the heart, which translates to events. In fact, in people with CHT, existing CHT, if you had high detectable troponin, the outcomes were extremely bad. 70–80% of them were dead within 8 to 10 years or so. Now, we know that it's robustly predicting events. The next question is, what do we do with them? So far, there have not been much data as to what reduces the troponin. Physical activity seems to be associated with lower levels of troponin. We had an abstract in ACC which suggested that beta blockers may have some value. So what to do with people with elevated troponin remains to be studied. Is it just going to be a simple control the risk factors, take care of the blood pressure, or will there be targeted therapy remains to be studied? So in summary, troponin and BNP are emerging as excellent markers of general cardiovascular health. We are seeing a shift or an addition of troponin in beyond myocardial injury to actually primary prevention, where troponin is able to predict future mortality and heart failure. What to do with these and how this goes on in the future have to be further studied. I just wanted to acknowledge people who helped me with this presentation and slides for this. And with that, I'll take any questions. I will read out the questions that I have already and answer them as I have any. So far, at this point in time, I have no questions. So if you have any questions, please feel free to enter it in, and then I can answer that. First question I have is from Samuel Hunter from American Shea Butter University. Is troponin levels reliable for the assessment of heart failure in patients with degenerative muscular disease? In general, it should be, especially if you're using the isoforms that are different between muscular disease, between skeletal muscle and cardiac. In other words, troponin T and troponin I. Troponin C, since it shares homology, in other words, the assay are similar across both the heart and skeletal muscle, would be difficult to use. But troponin T and troponin I, although it's also present in muscular disease, the tests that we use are sufficiently different that it should be able to detect the two of them, or be able to delineate between the two of them. Are there any other questions from the audience? Okay, at this point in time, I'm seeing no other questions. So if that's the case, I thank you for your attention. Hopefully this was useful information for you about the emerging value of troponin as we move forward in a primary prevention standpoint. Thank you very much.